Hello, my name is Charles Small. I will be the attending for week 8. This week we have the case of an 89-year-old Caucasian woman, body mass index, or BMI, of 17.2, with a known medical history of hypertension, rate-controlled atrial fibrillation, hypothyroidism, aortic insufficiency, lymphedema, and hypoxia secondary to partial lung resection, on home medications of warfarin, levothyroxine, metoprolol, montelukast, furosemide, ipratropium bromide, and fluticasone, presented to North Shore LIJ of Plainview's emergency department at 2:30 p.m. after a witness fall not associated with head trauma or loss of consciousness. Her vital signs on presentation were blood pressure of 144 over 81 millimeters of mercury, pulse of 119 beats per minute, respiratory rate of 18 breaths per minute, temperature of 98 degrees Fahrenheit, and oxygen saturation of 85% on room air. Our patient's baseline oxygen saturation was unknown, and she denied being on home oxygen therapy. On physical examination, our patient was not wheezing on presentation, but revealed shortness of breath on room air with diffusely scattered bronchi. An electrocardiogram, or ECG, revealed atrial fibrillation at 113 beats per minute, along with right bundle branch and left anterior fascicular block. At 3:30 a.m., our patient suddenly became bradycardic and progressed to asystole. She was found to be pale and pulseless. Cardiopulmonary resuscitation, that is CPR, was immediately begun following an advanced cardiac life support, or ACLS, protocol. Initial respiratory support with a bag mask was obtained, and our patient's trachea was secured with intubation at 3:32 a.m. As per the ACLS protocol, 1 milligram of intravenous epinephrine was given, followed by 40 milligrams of intravenous vasopressin given at 3:36 a.m. Our patient received her second dose of 1 milligram epinephrine at 3:40 a.m. Finally, at 3:46 a.m., our patient received 1 ampule of sodium bicarbonate. Our patient remained unresponsive to continued resuscitation efforts, so CPR was abandoned at 3:48 a.m. Right femoral access had been attempted during the resuscitative effort, and cardiac monitors were unwittingly left on our patient during cleaning and removal. At 3:51, before the complete removal of the femoral venous catheter, a single ventricular contraction was noticed on the monitor. The single contraction progressed to a couplet, then a triplet, and finally into a normal sinus rhythm with a palpable pulse at 3:53 a.m. Her initial blood pressure was measured at 80 over 50 millimeters of mercury, and our patient was started on a norepinephrine drip at 10 micrograms per minute through femoral venous access. A right femoral arterial line was also established for continuous blood pressure monitoring. Her blood pressure stabilized at a mean arterial pressure of 70, and our patient was transferred to our intensive care unit, or ICU, at 4:30 a.m. In the ICU, a hypothermia protocol was initiated, and vasopressors were titrated to maintain systolic blood pressure greater than 90 millimeters of mercury. Unfortunately, at 10:55 a.m., our patient went into ventricular tachycardia, and despite resuscitative efforts, our patient was pronounced dead at 11:03 a.m. The prognosis is the Lazarus phenomenon.